Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Hey, welcome back to the Prolonged Field Care Podcast. This is Paul, and for this episode, I'm going to be joined with Doug, Dan, and Dennis. They're going to be helping me talk about pain control and sedation in an austere environment with limited resources. As you can recall from the last one we talked about, it was our case discussion number 7. We had a gunshot wound to the leg and an unarmored mounted patrol. So the issue in this one was a sandstorm, which could very easily happen in many of the environments that we go to. And we also sent out a survey to you, the listeners and readers, to see what you would do, and we'll talk about some of those. Near the very end, don't miss Dan and Doug talk about PTSD and why everything that you may have heard recently may be wrong. I hope you enjoy it. All right, so during our survey questions, we gave people a choice. What was your preference in controlling pain in this situation from most preferred to least? And initially this was a drag and drop, and then later on we moved it so that you would rate it from 1 to 10. So a couple of the options included ketamine and ketamine drips. You had oral opiates, IV analgesia such as fentanyl, hydromorphone, and you also had some sedation such as benzos and propofol. So what do you want to say on this topic, Doug?
When I approach the use of sedatives and analgesics, the first question I want to answer is, what's my primary goal? Am I treating pain, or am I trying to sedate somebody for a procedure or sedate them for some other reason, like being intubated and on a ventilator? This is obviously a case where somebody's got severe traumatic injury and the goal should be analgesia. So on the list of medications that we gave for this scenario, the pure analgesics are morphine, the oral opiates, the fentanyl, the hydromorphone, also known as Dilaudid. And then a regional nerve block, I guess, could be basically a regional analgesic. Ketamine is a mixed analgesic and sedative. It has both properties and can be used for both purposes. It's kind of unique that way, but for this purpose, it's a perfectly fine analgesic. Then your pure sedatives in this scenario are propofol and midazolam, which is a benzodiazepine. So, goal number 1 is you're going to treat pain. Then you want to pick a pure or an agent which is primarily an analgesic. And then when you get to selecting which of these analgesics you want to choose, then you get into considerations of what is your side effect and what other considerations are in play. So one of the things in this situation I would ask is this a guy that needs to stay in the fight, right? Is this a guy who needs to maintain 100% of his mental status, provided he has enough blood pressure to perfuse his brain and have a mental status? He has an adequate blood pressure, so the answer to that question is yes. If he does need to stay in the fight, then that kind of sways things towards a regional analgesic, because you're not going to give him any mental status alteration with any of the other medications. However, bilateral lower extremity injury, it'd be tough for him to stay in the fight, and he's pretty much committed to being a litter-bound patient. So those two considerations, plus my own personal preference to use systemic analgesics, would lead me to picking one of the systemic analgesics, just because I'm not that experienced with regional anesthesia. And in this case, I want to pick a drug that I knew. So of the systemic analgesics, then all of the opioids are going to have a risk of suppressing his respirations, right? Your morphine, especially your fentanyl, and sort of to an intermediate extent, your hydromorphone. And so, unless you're dosing really well or are prepared to take an airway, I'd probably lean toward picking ketamine, because it's going to give you a good degree of analgesia with pretty much no risk of respiratory depression requiring intubation. Fentanyl can be a really tough drug to dose. You can really snow somebody quickly, snow their respirations and have to take the airway quickly. So I would lean toward ketamine. And then the use for the sedatives in this situation would be to treat some of the side effects of the analgesics. So, with ketamine, the well-known side effects are going to be emergence delirium or hallucinations. Midazolam's a great second drug to treat those side effects. It also can extend the effect of the analgesic. So good second-line drug, but not a first-line drug. So that's kind of what I would go with.
I think everybody can agree when it comes to analgesia, there is 1,000,001 techniques. Everybody has their flavor of choice. So I don't think we're going to get much traction going down that route of picking one technique over another. What I do think needs to be really hit home are the priorities. Like, how are you going to set up your decision on what technique you're going to pick for what situation? The first part of this, and this is going to come out later in the analgesia and sedation CPG, that's in the very first part of it, they laid out the 5 priorities. And we've all learned this in T-Tri-C. So the first priority is keep your casualty alive. It seems obvious because that's our whole purpose, but it gets a lot more difficult when your buddy is in a lot of pain, but you can see that his vital signs are not going to support the analgesia you're thinking of, especially if you're not carrying any ketamine with you. If all you have is opioids, don't give it to him. Do something to stabilize that patient to get him to that point. Then treat his pain. And that kind of leads into our second point. Sustain adequate physiology to maintain that perfusion. You have to get that perfusion high enough to kind of buffer the effects of this analgesic. We already know that opioids are going to drop his blood pressure. So give him the fluids, give him the resuscitation to get him above that point. Relieve the pain. We're not talking about sedation. We're just targeting analgesia. If that's our problem, then target the problem. Don't dance around with it with other things. Making him quiet does not mean you're actually treating the pain. Maintain safety. Agitation, anxiety, these are going to make this patient do things that he wouldn't normally do. Steve is not Steve anymore. He's a patient who's been injured, and he, in his mind, is near death. So he may do things that he wouldn't normally do. He may react differently. So we need to maintain a measure of safety just by the nature of our environment. And then after that, the 5th point, there's no awareness. And this is our last priority, because at this point, it's a nicety, really. We're going to make the environment comfortable. We're going to take all these bad memories away. We're going to package this patient up nice for his trip. So what do you guys think about these priorities?
I had another priority that I thought about after I got done filling out mine, because I picked the ketamine as my first choice, just like most of the other people. I thought ketamine drip would be something easy. I'm comfortable with it. I feel pretty good about using it. And then it was about 15 minutes after I submitted, I started thinking, it's like, what if I got casualties again? I mean, the environment that I'm in, what if we have them again? And this time I have somebody that did get shot in the chest and was in a lot of pain, and I needed that ketamine for that guy. That's where I started to rethink my whole stuff, and I got into a new priority that I wanted to hit was, what do we have to sustain us if the sandstorm stays for more than just 24 hours and we're screwed for about 3 more days? And I'm sitting here and I've got to deal with that same medication for 3 days on this patient and maybe others. I don't know, what are the thoughts people have with that? That's where I started wondering if I wouldn't start using the oral medication, or I would try to conserve my IV resources, or mainly conserve that ketamine because I'm comfortable with it on a tougher patient than this one.
That's a really interesting point. One of the things I did when I prepared for this discussion was calculate out for a 100-kilogram guy exactly how much medicine I had, specifically what dose of each medicine could I give for a 24-hour period for the scenario. And if the amount of ketamine is really as advertised, 10 grams, you could treat a lot of dudes with 10 grams of ketamine for 24 hours. I at a 100-kilogram guy, for an easy way to calculate your initial rate in a ketamine drip is take their weight in kilograms and divide by 2, so at 50 milligrams an hour, Well, at 10 grams of ketamine, I calculated we could run it 415 grams an hour. So that's plenty of leeway for treating other casualties. But it is a good point. Another factor in favor of maybe picking another agent to save your ketamine is that this guy had a really stable blood pressure, or really good blood pressure. I don't know if it's stable or not, but right now it's pretty good. So he's got in a systolic in the 110s. He's got plenty of room to give an opioid, and if he tolerates that and his blood pressure stays up, then you may save your ketamine for somebody whose blood pressure is less stable.
Which I think is a very good point, and that kind of leads into our next topics of how are we going to set this up. We're very good in our training and maybe the information we look to educate ourselves at as far as doing the procedure. When you think about intubation, all you're thinking about is putting a laryngoscope in the mouth. Not a lot of people put a lot of mental horsepower into prepping for that intubation. And giving analgesia is the same thing. It's another procedure that I'm going to use to treat this patient. So I think knowing how to prepare for such a thing is really important. And I think we all can universally kind of agree on that. So I think in one of our previous podcasts, we talked about mismade. Dr. Powell, what do you think about the mismade and medics doing this?
Well, in terms of even in terms of prepping it to set up to be prepared to manage an airway
Right.
and other aspects of that, absolutely, preparation is key for any major medical procedure, and giving IV analgesics or sedatives is a major medical procedure. Big thing is know the side effects of your drugs so you can plan for them. And then the second thing is give a test dose, which will allow you to assess those side effects. I remember a trauma patient we had in the intensive care unit once, and he could not tolerate any opioid whatsoever. And usually people, if they're intolerant to one opioid, don't have the intolerance to another. But we gave him fentanyl, which is for trauma patients kind of our initial opioid of choice. He was intubated, so we didn't have to worry about the airway, and he got hypotensive. We gave him Dilaudid. He broke into a rash, and even with subsequent doses, he wasn't developing a tolerance. So we wound up having to manage him with ketamine and another medicine called Precedex, which you guys don't carry for his analgesia. So the test dose is key because it'll tell you a lot. It'll tell you how much is effective to manage their pain. It'll tell you what kind of side effects they might have. And if they don't have any, then you can drive on. Ketamine, your big side effects are going to be mental status, right? They could hallucinate, they could become delirious, they could become agitated, and you would want to have. I would treat with ketamine if I didn't have Versed in my kit, but I would really prefer to have some Versed just in anticipation of those side effects. With narcotics, the major side effects are itching, rash, nausea, and low blood pressure. And so low blood pressure, I'd probably have an IV bag hooked up that I could run a bolus in if they tank their pressure, just so I could bring that up again, and either do a smaller dose, give it more slowly, or switch to another medicine if I had it, if the blood pressure fell too much. And then the other big one is nausea, and I'd try to have some Zofran, some ondansetron, which we do have, and give it IV. Ondansetron, it's very hard to, if you're about to puke, it's very hard to give an oral medicine to keep you from puking and actually keep it down. So IV or IO Zofran is really what you should have. And then with all of the narcotics, you could suppress their respiratory drive. I wouldn't necessarily be set up to intubate or to crike. I would be set up to mask ventilate. And this is something we throw at students in some of our practical scenarios is, they give them, and benzodiazepines are really famous for this, for suppressing respiratory drive. We make the patient delirious when they're on ketamine. They give 2 of Versed. They're still delirious. They give them 6 of Versed. Now they've got 8 of Versed in. We give them a respiratory rate of 4. And then the next thing you know, they're setting up for a crike. Well, if you knew your side effect or your pharmacology of Versed, it wears off in about 15 to 30 minutes. That's a patient you really should be mask ventilating. You don't need to go to the work of taking an airway, but definitely have your mask ventilation set up in case you overshoot on a narcotic or benzodiazepine.
And I think that's a very good point. But I also think it's easy for us to read in a book and say, okay, this drug is going to have this effect. It's much different on the battlefield. You have just different patients, and then you have the background of a change in physiology with shock, the injury pattern themselves. How did that affect it? So with that, the myths made, when you go back in the podcast, we don't mean you have to break out all this equipment. It's just that in your head, you have to have an answer for all of those parts. Your machine, it's not an anesthesia machine, it's a BVM. Do you have one? You have it ready. Suction, your little hand suction device, okay? Monitors, do you have them up and ready to go? Is everything warmed up? An airway, doesn't necessarily mean you're going to have to tube this guy, because that is another mess that you're going to have to deal with. As soon as you decide to intubate, there's a whole other spectrum of things you're delving into. Don't be afraid to just bag this guy. If you gave him a little bit of too much, which is easy to do, ventilate for him. Work your way out of this mess. Don't be so quick to go ahead and crike this guy, because you're just delving into a whole other level. Make sure you have enough drugs. You know, how many people actually, before you punch out, have took the time to look at my mission, the possible or probable casualties I'm going to have? Do I actually have enough to follow my own plan? You've briefed it to everybody. Do you have enough stuff to cover it? What do you guys experience?
I know where I came from. That was actually a big deal, where a medic would request a certain amount of what ketamine or whatever other narcotic he was requesting. And then we had to say, hey, that's really not enough. 4 vials of ketamine isn't going to get you through your 6-month deployment. Why don't you go ahead and take 10? So we made a standard minimum order of a guy would go pick up their meds from MedLog, and that's what they would get.
My experience with orders, I didn't do a lot of dealing with the teams when I was on a team with complete medical orders and stuff on their narcotic side. But something that did come to me just thinking about it as an instructor, something I've seen a lot in our PFC that we teach here in the SOCM course, is on a whole different standpoint, which really hits to what we're talking about here, is documentation. It's something it just came to me that I was thinking, I've seen this happen in our lanes in PFC where a guy is giving a drug and has that bounce in blood pressure. It drops down and didn't really realize why he had that change in his vital signs. And then they go straight into, hey, he's not breathing that much right now. He's breathing 4 a minute. Let me pull out all my equipment and let me go ahead and go into this intubation, or in this case, because his LOC is too high, let me go into a crike, you know? And I think that was a great point, because if you're using a really good documentation sheet that's paying attention to vital signs as they happen, or like that one that's on pfc.org that we've incorporated into our training, at least a guy can look at it and say, hey, this intervention was done here. This is the new vital signs I have from that intervention. So now I know why that particular thing is happening. And once the students in our block understand that, then they start incorporating that anesthesia log sheet that we have, or that PFC sheet that we've been using. And I think they understand the importance of doing something like that. So I really wanted to share that, because I think that documentation is a keystone to using this.
Dan, that's an awesome point. And in prolonged field care, you know, one of the big things that you have to do is transitions of care. You're going to and provide meaningful information at transitions of care, which can be really the highest risk to any patient in a hospital environment, is when their care transitions from one team to the next. And so by documenting the way you discussed, then somebody who assumes care of that patient later down the road either doesn't give that medicine because they see that it had that side effect, or they give it carefully knowing that it had that side effect. You're protecting your patient going forward with your documentation, you know, not just scribbling down numbers. I did want to talk about the planning question that came up. Paul had a great point. For prolonged field care. We're really bending some minds in medical logistics with the amount of equipment and especially medications that needs to be drawn for these environments. For our guys, you know, we sort of use as a planning factor for analgesia 200 kilogram guys that you need to give analgesia to for 48 hours. And at 100 milligrams an hour. So double the starting rate as a fudge factor. That gives you your boluses for movement or your boluses for procedures, and then 200 kilogram guys for 48 hours, that's 4 people for 24 hours or 1 guy for 96 hours. And that seems to work out pretty well. And that breaks out to about 2,500 milligram vials of ketamine. And, when we first went to MedLog and the guys say, I want 20 milligrams of ketamine, I thought their head was going to explode because they're used to giving like 2 or 3. But when we explained it, did the calculations for them, then they got it. But there's an education factor for MedLog for prolonged field care that needs to be addressed.
Yeah, I think the big thing is, especially as prolonged field care becomes more and more dominant and we start seeing these protracted evacuations, just education. MedLog has never had to deal with anybody like this. And in the past decade, they're used to handing out 2 or 3 vials of stuff and getting back 3 vials of stuff. So they kind of feel like they have a handle on it, but we're punching out into new areas. So there's going to be a whole new learning curve. So that documentation, incredibly important. Not only just seeing trends in your patient, but afterwards in your SOAP notes, you can say, look, I actually used 20 freaking vials of ketamine on this guy, and I was still worried that I didn't have enough. So, not only the commanders can see that, the battalion docs can see that, but the MedLog guys can see that, and they start reforming those opinions for these particular missions. Next, I kind of wanted to go into how to approach giving analgesia. We're used to in T-Tri-C, especially when it was hit them hard up front, you're only going to have to wait 20, 30 minutes before a helicopter comes anyway. So if you didn't get around to it, nothing bad's going to happen. But obviously nowadays things are a lot different. A lot of different regiments have different protocols, like the Rangers. They hit them very heavy with ketamine up front, and knowing the pharmacology is going to provide you a much safer method to get there. So what we're going to be talking about is baseline pain control and breakthrough pain. So my approach to this, your baseline drug. What is it going to take to get this guy comfortable when he's still and you're not doing anything to him? What does it take to get that? In my mind, I need a bridge to get from where he is now to this base pain control. And I want that base pain control to be something that's going to last for a long time. I can adjust from there, but I need it to last for a long time. So I want a long-acting drug. But that bridge to that point, maybe I need a powerful short-acting drug. So to my mind, that's where ketamine comes in. Maybe fentanyl. It depends on people, on your comfort with it and your experience with it. That's my take on that bridge to get there. You want a short-acting, powerful drug. I can get to that point where he is under control. Things start slowing down. Everybody starts getting comfortable with the situation. And by the time that short-acting drug starts coming off, that's when my baseline pain control comes on. Morphine, Dilaudid, something that's going to last for a long time. It's going to give me a big bang for my buck for that patient. What, Dr. Powell, what are your thoughts on that?
No, that's exactly right. Part of your plan needs to be for baseline analgesia and then breakthrough. And it was already demonstrated in the case that every time this guy hit a bump in the road, he was in pain and pretty much crying out for a breakthrough pain regimen. For the drugs that we have in this case, your longer acting and narcotics are going to be morphine the longest, Dilaudid the next, and fentanyl really too short to be useful as a baseline pain medication because it's going to wear off after 15 to 30 minutes. And you really, you don't want to be pushing IV fentanyl every 15 to 30 minutes. That's number one, it's going to run through your supply. And number two, you're going to be too busy with other stuff to do that. I would caution that you should never run a narcotic or a benzodiazepine as a straight infusion, as a straight drip, unless your patient has definitive control of the airway, a cric or an endotracheal tube. Could you do it and they not have respiratory failure? Sure. But there are, a lot of lawyers have made a lot of money on patients who got too much fentanyl or too much benzodiazepine, and had respiratory arrest when people weren't looking. And it can happen, and if it can happen, it shouldn't happen to you. So use those for your breakthroughs. Morphine is good. In this case, you barely had enough morphine to get through the 24-hour scenario at 5 milligrams every 2 hours, which is kind of an average. Morphine you need to dose somewhere between every hour and every 4 hours, depending on how your patient's metabolizing it and what their own pain requirements are. So every 2-hour dosing is kind of an average. You could get through it with the morphine you had, but at 10 milligrams every 2 hours, you were going to run out, and then you'd need to switch to something else. And so you could use hydromorphone. So you could do morphine pushes every 2 hours, Dilaudid pushes when you run out of morphine every 1 to 2 hours, and then use your fentanyl for breakthrough. Alternately, the nice thing about a drip is that you can kind of not have to adjust it quite so much for baseline, and you don't have to push it for baseline. And ketamine is a great drip because you're never going to put somebody into respiratory arrest. And then for your movement, you give a narcotic. Any one of these probably fentanyl or Dilaudid would be a better push for breakthrough pain. Morphine is a little bit too slow acting for breakthrough pain.
Yeah, if we look back to this survey, one of the most popular things on there was the ketamine drip. And we've hit ketamine over 4 podcasts, maybe 5 podcasts now. And so I think that was why it's on the top of so many people's lists. And what I see with a lot of my students are when they go to do a ketamine drip, they just start dripping it in. And they never get to that therapeutic dose. They never have the loading dose. And I know that, Dan, you do teach your students that. I've seen your sheet that shows here's your loading dose and then go to your drip. What do you have to say about that?
Well, we have the same problem. We first start out, a lot of our students will want to just use the drip, the ketamine drip, and think that that's going to work without the loading dose. And we have to constantly teach them that in our PFC too, that drip is to help adjunct the bolus ketamine that you're probably giving them, which was just explained. Dennis just explained that. So yeah, we're having the same problem. We're trying our best to try to fix that. And I think by the time they get done with PFC in the SOCM course, I think they have a better grasp of it. But it sounds like when they get to SFMS, they're still seeing the same thing. Maybe some of these guys will listen to this and understand that somehow, whether you're using a ketamine bolus or you started off with a morphine or you used your fentanyl lollipop or something out there in the field, that once you've got that that immediate pain controlled out there, that drip is just going to adjunct on top of that and help keep them at that plane, and then still keeping something left over for that breakthrough. I think that would be important.
That's one of those points that needs to be reemphasized in ongoing training. They're doing a great job teaching it here at the schoolhouse, but when you get out and you're doing your exercises, look for that as a point of emphasis when you're doing your medical exercises. If they just start a ketamine drip without a bolus, then keep that patient's pain at 8 or 9 or 10 out of 10 until they get the bolus and their vital signs to match. Make them tachycardic, make them tachypnic, make them give them that bolus, whether you're a medic running the lane or a doc or a PA running the lane. Because we're finding with prolonged field care training that medications are and drugs are one of the areas that people need the most refreshing on to stay current, because they're not in hospitals, using it like docs and surgeons are every day. So we need to figure out a way to overcome that.
Yeah, Dr. Powell, that's an important point. I think in training is training as you fight. I think is the most important thing that you can do out there. And there's ways to take your training to the next level. And one of those ways is creating your own drug labels that mimic the drug labels you could really see in theater, and getting some normal saline vials, putting these labels on the normal saline vials and using them in your training. This way you'll actually get used to what you need in your kit, how you need to draw it up, and other guys that are around you, guys that you might be using that aren't medical professionals that are going to help you do this stuff on your team, will be able to actually see how to put that stuff into play and what stuff you need to do out there in the field. And I think their training will just really benefit.
Yeah, absolutely, Dan. I think it's no different than doing our quick draw training. You train to change magazines. You train to fix malfunctions. This is no different. There's a reason why we go through all that training with weapons. It's because we know things are going to go wrong when the stress comes on. Medications are are no different, and they require a lot of thought with very little gross motor movement doing that skill. Dr. Paul, I did have a question because I honestly I can't find the answer. We understand baseline pain control. We understand what breakthrough pain control. Either I'm doing something to somebody or the drug I'm giving is actually starting to wear off. I don't understand is how often do I have to react to breakthrough pain before I start adjusting my baseline pain control? How do I know that my baseline pain control is not working on this guy, and I, instead of constantly having to bump him every so often, how do I know when to just raise my baseline pain control?
That's a great question, and you did put me on the spot, but I'm going to answer it anyway. A lot of this has to go to that whole, test dose idea that I talked about earlier. And the other thing that it goes to is understanding a little bit of the pharmacology of your drugs, right? And I hated pharmacology. When I was in medical school, I looked at those lectures and my eyes just glazed over. And I was like, I'm never going to need pharmacology. I'm going to be a radiation oncologist. I don't have to do any of that. So then I picked intensive care, and now all I do is think about pharmacology and the physiology of drugs. So, it's possible to learn. It's possible to love. And I do teach this to the guys in our unit and in classes that I give, that the answer to your question is really tied up in the pharmacology of your drugs, right? So if your drug is if you're consistently giving bolus pain medicine before your drug should reasonably be expected to wear off, then you need to give more of your drug as a baseline. So let's say ketamine IV, right? Not drip, but IV push. Normally that should last about 20 to 30 minutes before you have to give the next dose. If you're giving boluses at 10 and 15 minutes repeatedly, then you need to go up on your baseline dose. What's a good amount to go up? If you're conservative, 25%. If you're not so conservative, 50%. But something like that. Pick a number and do it. And then, reevaluate and have criteria to go up again, right? So if you let's say you got a 100 kilogram guy, you're doing 0.2 mgs per kg, which is 20 milligrams, right? And then at 10 minutes, he's in pain. And so then you're going to go up by 25%, which is going to be about half a milligram, right? 0.4 is going to be 0.45 is going to be 25%. So then you're going to go 2.5 milligrams, 25 milligrams, or 30. You give that, and then if it lasts 30 minutes, you're good. If it wears off in 10 minutes, then maybe you go to 40. So that's one way. And that's kind of how I would do it. Morphine is a drug that has a kind of a very wide range of absorption and a wide range of half-lives. If you're giving morphine more than every hour, you should go up on your baseline morphine rate. If you're giving Dilaudid more than every hour, you should go up on your baseline Dilaudid rate. And we already talked about fentanyl as an IV push not really being a good baseline pain med. So for those three, that's kind of how I would do it. I would see if the drug's wearing off before you would expect it to wear it off. I would know when you would expect it to wear off. And then if it is, I would go up by, somewhere between 25 and 50%. And see how it's going and keep going until you get it lasting as long as it should last. That makes sense?
I think we haven't really talked about regional anesthesia and regional nerve blocks. And a lot of people here aren't really comfortable with that, but we do teach our students that. And it's been taught in our schoolhouse now for about 4 years. And we've had a very high success rate. There's an article in the Journal of Special Operations Medicine on just all the complications that we've had, which are very low, and the high success rate. Now, in this scenario, we stated that you had 1 or 2 vials of, I think 2% lidocaine with epi. It's not going to last you all 24 hours, let alone 96. But what it can do is if you're going to do a painful procedure, let's say you're going to try to convert this tourniquet, you could go ahead and do a regional nerve block, whether it's with the StimiPlex or with the ultrasound. You can get out your MARA handbook and then go ahead and do that. You can go ahead and pack it and try to take down that tourniquet. So for procedures, it's absolutely a viable option. It's going to save you a lot of meds because if you didn't use that, you're probably going to have to use a higher dose of one of those other things for a very painful procedure, such as packing that wound.
Yeah, I definitely agree with the comfort of it. Being when I went through the course, this was not really part of the. I won't say it wasn't part of the course. We were taught it. We didn't see it again after we got out there on a team, and I don't think that's where I really had a big thing that I circled about twice on my sheet of paper over here was about practice. I think one of the most important things we could probably do as medics, or those of you that are out there listening to this, is probably look at practicing this, because if you aren't comfortable with it, or you're thinking about it right now and not sure you could actually maintain or get rid of the pain that your patient has using regional anesthesia, that's one of those things that you'll definitely need to talk to whoever you work for, your battalion surgeon or something, and set up a training program so that you can get comfortable with it. And then definitely look at the good resources you could bring with you that could show you how to do it, because you'd be amazed that you could look at the directions and really do a lot more than you think. So do this type of training so that if we can't do it on a human, we could do it on a simulator.
No, I think that's awesome. Simulators are outstanding, especially getting that muscle memory, start those thinking processes, get the majority of that knowledge in your head in that muscle memory so that, you're not worrying about that stuff. You have the experience, you've seen it done. Then when the smaller things that start creeping in, Murphy's Law works on everybody. You're prepared for it. Coming into my next point, which is safety. When your buddy has been wounded, we want to, take care of that guy. We want to make sure he doesn't feel any pain. We want to take any kind of discomfort away from him. That's not what analgesia is. Okay, we're not doing anesthesia. And I think people kind of get those things confused. When you're doing analgesia, you don't really even need to take him to zero pain. Okay, he's not going to be, nobody died from pain. We want to take it away because we care about this patient, but we don't need to take him to zero. So you don't have to snow this guy. There's no requirement to make him zero on the pain scale. Even in the hospital, and correct me if I'm wrong, Dr. Powell, but if your pain is, a 2 or 3, you may not even get any pharmacology. The nurse may fluff your pillow up, change the television, turn the lights on or off, pat you on the back, but odds are pretty good you're not going to get any pain, your analgesic drugs, when you have a pain scale, 2 to 3. Aim for that. Then you can, you've taken the vast majority of the pain away, and then you can do other things to try and make him more comfortable. That's what we want to do. That's our target. What do you think about that, Paul?
Yeah, I think one important question to ask, not what is your pain on a scale of 1 to 10, but is your pain under control? Do you need more pain medicine? And you can ask him that. And before, when he said, might have said 4 out of 10, but when you asked him that question, like, no, I don't need it. So
Right.
there's a big difference there. I know we have one study, we just printed it out from World War II, where 70% of the respondents in that study didn't need any pain medicine whatsoever, combat casualties. So this is exact opposite of what we were talking about before. We had, what did you say, almost 30% come in with
Yeah.
no analgesia. Well, make sure you ask them. If they don't need it, then he doesn't need to get it right then. Now, be aware, if you're going to do something painful, you can go ahead and pre-treat that, but just be aware that it's not 100% every time.
Oh, yeah, absolutely.
So going back to when we were talking about personnel and wanting to push pain management on somebody and basically snowing them out even though they don't necessarily need it. I know a lot of the instructors I get to work in my office in Trauma 3 and some of the students, they get this idea basically off of some of the stuff that they've read off the internet, I'm sure, about the correlation between pain and PTSD. And I think a lot of guys want to snow their patient out because they're worried that they'll have a PTSD problem later on if they don't do that. What's your thoughts?
It's a great question. I'm going to stray a little bit from my subject matter expertise on this, but not too far, because we deal with this problem in the intensive care unit and in clinical, hospital environment. Delirium in the ICU is a real thing because you're in an unfamiliar environment with a completely jacked sleep-wake cycle, which is not dissimilar to extended medical evacuation in a combat situation. And there is such a thing as post-ICU PTSD. From the reading that I've done on the subject, it's actually interesting that there's a school of thought that the absence of memory or gaps in memory is a higher risk for PTSD than even the presence of bad memories. And so, to answer your question, Dan, if you take that line of reasoning, then being aware of your surroundings, even if that awareness includes some level of pain, may put you at lower risk for PTSD than being unaware and having gaps in your memory, specifically gaps in memory caused by amnestics, i.e. benzodiazepines. Benzodiazepines have been associated with post-ICU PTSD, and the hypothesis is because they create gaps in memory, and then your body, and then your mind, struggles to fill in those gaps in the memory, and that's one of the potential engines for the development of PTSD. So I guess if I were to extrapolate that admittedly very thin literature review and research into answering your question, I would tie it in with Dennis's point that shoot for a reasonable level of pain, but don't shoot for zero pain and zero awareness, and that may be your best strategy for avoiding PTSD, at least due to pain.
I think Dr. Powell, wasn't that the analgesia first study that they were looking at using only analgesia and not the sedatives like benzodiazepines or any other drugs like that. And I think they were also talking about in that paper that the benzodiazepines, not only were you losing gaps in time, but while you were somewhat lucid, as the drugs were either coming on or starting to come off, their perception of reality was changed. So kind of like ketamine, the high you're coming out of. And that was very frightening because they were in the semi-lucid stage, and their mind started playing tricks with them about what was reality and what was not reality. And then in that study, they were looking at if we just took care of their pain, we put them in that, on the pain scale, a 2 or a 3, they were able to be awake. They could talk to people if they were able to talk. But they restored their sleep-wake cycles. They had much better outcomes. They came off their vents faster. They came out of the ICU faster, and they had a lower incidence of that the post-ICU PTSD. How could we possibly take that and use it in our practice? I think it's just keeping things simple. We keep it safe. We shoot for the pain scale, a 2 or 3. Make sure he's comfortable. How about that? Keep it even simpler, that he's just good with where he is. And try and just keep it as simple as possible. I think that's, making a bomb-proof plan that this is my goal. I'm going to take him from where he is now to this level. I'm going to try and do that with as few drugs as possible, within reason, using a short-term and long-term analgesic drug. And I'm going to use these as my parameters to guide. I'm going to monitor. Well, I know my pharmacology, so I know that this drug is going to last this long. If I see it coming off too soon, then I'm going to increase my baseline. I know that if I'm going to do a procedure or we're going over rough terrain, it's going to hurt him, then I'm going to bump him. I'm going to give him bumps. That's going to take him over this, but I'm not going to maintain that. I'm going to let him come back down to baseline. I think the key with this is just making that bomb-proof plan that is focused around safety and getting to the goals that I want.
Yeah, that sounds good. And one thing that I like that you said right there was making a goal, having a plan. So when you're prioritizing a care plan, which you should be doing, listing out all your problems, all your issues that you have with that patient, whether it's an injury or a problem like pain, then you can make that goal and you can try and strive to meet those goals as you go along. All right, well, that's going to wrap up today's discussion. Thanks you all for being here today.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.